Next talk will be given by Dr. Andy Burkowski. He's a neurologist and specializes in sleep medicine here at the University of Michigan. He's a native of Southeast Michigan and earned a medical degree from Wayne State University. He then completed his internship at Henry Ford Hospital and his residency in neurology at the DMC, Wayne State University. He then completed a fellowship in sleep medicine at Stanford University and is board certified in adult neurology and sleep medicine. He actually has a clinical and research interest in restless leg syndrome and is involved in teaching and supervising sleep medicine fellows in training, and he'll be talking about sleep disorders in Parkinson's disease. Let's welcome Dr. Burkowski.
So interesting question, what do Hillary Clinton, Donald Trump, and all of us have in common? Probably not a whole lot, right? But we all sleep, so that's something we all have in common. And that's what I'm going to talk about today, because it's something that everyone does as a human being. And so this is the outline of the talk today. We're first going to talk about a little bit why sleep is important. And we're going to talk about certain disorders that are common both in sleep and in Parkinson's disease. And the most notable one is REM sleep behavior disorder, which is very, very commonly found in Parkinson's disease. And restless leg syndrome, insomnia, which is the inability to fall asleep, obstructive sleep apnea, which is common to the entire population, but also can be happening in people with Parkinson's disease. We'll touch a little bit on the problem of being sleepy during the day when it's not due to any sleep condition that we've talked about. And then hopefully we'll have time for questions at the end. So. Sleep is important. For one thing, we spend about a third of our lives sleeping, so that's a lot of time. So it's probably important that sleep is of good quality, because that's a good portion of your life. As most of you know who've had good nights of sleep versus bad nights of sleep, the studies show that different things can be affected by immediate sleep quality. And one is that memory improves, thinking, concentration also improve with good sleep. Mood, feeling good about yourself, feeling happy, not depressed, that can improve. And when you get good sleep, you're not going to be sleepy during the day. You're going to be alert and awake. And also, distinguishing from sleepiness, you'll have more energy, because sleep provides a boost of energy. And a lot of studies have shown that physically you perform better, athletes perform better when they get more sleep. So as I mentioned, some of these conditions are more common in Parkinson's disease, and we're going to touch on a couple of them. And some of the conditions themselves are common to everyone, so people with Parkinson's disease may also have these conditions. And the important part is that most sleep conditions are treatable. And when we're in a kind of an area of medicine where not everything is completely treatable, it's always good to find things that you can treat that will help improve your quality of life. So the first condition I wanted to focus on is one called REM sleep behavior disorder. And this is a condition in which dreams which occur during REM sleep, rapid eye movement sleep. And that's a stage of sleep where we typically have our dreams in. And normally, in order to not act out our dreams, we evolve the ability for our brains to shut off our bodies. So almost all of the muscles, except for a couple, become paralyzed during REM sleep. And during this paralysis, this is when the dreams occur, and there's no movement that occurs. But in certain conditions, including Parkinson's disease, the off switch for those muscles might be turned on, and the off switch doesn't go on. So the muscles can be free for movement. And I included a link at the bottom. It might be, I don't think I'll be able to play it here, but there's a video of a man with Parkinson's disease that I showed. So basically, this sort of video, it just shows a person with REM sleep behavior disorder acting out his dreams, and it's available on YouTube. If you have a magnifying glass, you can see in the slide there. But basically, it could be pretty dramatic. People can yell and shout and even carry out conversations that they've had in the past or they're imagining in their mind. And it can be quite frightening, particularly for bed partners. And because it looks like, the patient's awake or the person's awake, but they're actually just acting out their dreams. So this symptom, or this condition, I should say, can come a long time before any type of Parkinson's disease symptoms develop. So this can actually predate Parkinson's disease if it is occurring. And the majority of patients now that we see in studies will have who have this REM sleep behavior disorder will go on to develop Parkinson's disease or another condition where the brain is not functioning properly over time. So a recent study in 2014 showed that in 5 years, when they followed patients, almost a third of them developed Parkinson's disease or a similar set of conditions. And after 14 years, up to 91% developed it. So this is an important condition because this can almost predict the development of a condition that's potentially treatable. So right now there is not much in the way of drugs specifically that can use to prevent the process of Parkinson's disease to take place, but until different blood tests come out and different other tests that can predict Parkinson's, this is actually a good, potentially a good condition to diagnose in order to predict Parkinson's when there are medications and treatments that come out for this. Now, this condition doesn't really disrupt sleep. It seems like it would, but it actually doesn't disrupt sleep quality because it's just the dreams are still going on and the person's acting out their dreams. And one thing that can be disruptive is to the spouse or the bed partner, that when people are acting out their dreams, it can actually wake them up, or it could be a danger to them because if they're swinging their arms and legs, it could actually hit the person they're sleeping with and injure them. So that's really the most dangerous part. So some of the symptoms that I mentioned include yelling or talking, conversations, often dramatic movements like punching movements, kicking movements. The difference between, there are other conditions where people do things like eat in their sleep or sleepwalk when they're asleep. But this typically, most people with REM sleep behavior disorder are moving around, but they never typically get out of bed and walk around. It's pretty rare. I did see a case where somebody stood up and started taking golf swings in the middle of their dream. They must have had a good round of golf recently. But usually people don't get out of bed. It's usually something that is confined to brief movements. And the person may actually wake up from these dreams and actually remember, what was going on in the dream that they were acting out. So it's typically diagnosed, first it's suspected by a clinician or somebody like the neurologist seeing a person, or even a sleep physician are usually the two groups of people who are looking for this condition. And I'll get into this later about what a sleep study does, but it can be, the diagnosis can be confirmed in a sleep study where it shows that during this REM sleep that there are abnormal muscle movements that are occurring during this stage of sleep. And there are other similar things. I mentioned sleepwalking, but there are things like nightmares and hallucinations, and sometimes people wake up confused from a certain stage of sleep. Those are different situations than REM sleep behavior disorder, and sometimes that can be distinguished by a sleep study. So just because somebody's having bad dreams, it may not be a nightmare. They might be acting out their dreams, or it could be a nightmare and they're not acting out their dreams or waking up from a nightmare. So it's important to distinguish between those. So as I mentioned, it's not disruptive to sleep itself, but it's potentially harmful physically because of the movements. So these are some of the things that, as a sleep physician, we recommend for people. One is if you're sleeping on your throne about 20 feet off the ground, maybe to consider lowering the bed, padding, if you have a hospital-type bed with side rails, to pad the side rails so that if someone's moving around, they don't injure themselves on the side rails, padding the floor, keeping nightstands and other things like large windows away from the bed so that if somebody's moving their arms or legs, that they don't put their hand through a window, which we've seen happen before. And sometimes spouses or bed partners have to sleep separately. Some people have two twin beds and they sleep separately in the same room. Some people move out of the room, which is pretty common in our sleep patients. 30% of all couples sleep separately. So it's not uncommon for people to separate themselves. And in patients, people where we have a difficult time controlling the movement, some people actually sleep in a sleeping bag so they can't flail around too much and injure themselves. So there are medications that are used to treat it. If the condition is there and it's not bothersome either to the person who has the condition or their bed partner, we don't necessarily give medications for it. But the number one medication sleep physicians use is a hormone called melatonin. And melatonin is a hormone that's produced in the brain, and it tends to go very high at night. It corresponds to sleep. So some people take melatonin as a sleeping pill. But in higher doses, the melatonin, and we don't know why, but the melatonin actually can suppress these acting out of the dream and actually calm down the dream behaviors. The main side effect is mild drowsiness, which is generally okay because it's taken right before bed, so it causes drowsiness when the person's asleep, and then it wears off by the morning. But some people can still feel a little bit drowsy in the morning from it. And it's not a pharmaceutical prescription medication. It's usually an over-the-counter supplement. But certain pharmacy-grade types of melatonin can be found where you accurately know what the dose you're getting is that can be prescribed. But it is widely available. Some of the other drugs that are well studied is a drug called clonazepam, or the brand name is Klonopin. And this drug is used for many different conditions. It still is used for seizures. Primarily now it's used for anxiety and things like panic attacks. And what the drug does is it actually slows the brain down. The processing of the brain is slowed down. So what it does is it helps to suppress the behaviors from occurring. And the problem with the drug is it slows the brain down. So there are side effects that can include drowsiness, and people might be at slightly more risk for falls when they're on the medication. So in someone with Parkinson's disease, this is not good because if you have Parkinson's, you're already at risk for falls. So this is a very effective medication, but it has to be used with a lot of caution because it can affect the mind, it can affect the ability to walk. So we have to be very careful with the drug, though it is clinically proven to be the most effective. There's an alternative drug that's not well studied for this condition, but it's used commonly called lorazepam, or Ativan is the name, and it's used for similar reasons to clonazepam. But it actually works for a little bit less time, so people tend to have fewer side effects. But because it's not as strong of a drug as clonazepam, it may not be as effective, but we sometimes use it. And there are other medications that we use, but none of them are necessarily proven in clinical trials. Now, this is one of my areas of interest. This is a condition called restless leg syndrome. And this is a very common condition. It's one of the 3 or 4 most common sleep conditions. But it's more common in patients with Parkinson's disease. So what is it? Well, there are 4 different symptoms that are sort of the hallmark of restless leg syndrome. And typically people get a creepy, crawly sensation or an unpleasant feeling in their leg. And most of the time they can't even describe it. And that's how you know that's what it is, because it's almost an undescribable feeling that they get. And it's something that's produced in the brain. It's not actually in the legs themselves, but the brain is feeling symptoms as if they were coming from the legs. And it's usually worse at night and when lying down or resting. People who have this have trouble on airplanes or in movie theaters because of the confined space. They can't move their legs around. And it tends to feel better when the legs are moving. And it tends to be, as I mentioned, almost always it's worse in the evening, though some people can get the symptoms during the day, but usually not as badly. So in clinical studies, it's more common in Parkinson's disease because the condition actually involves dopamine to some extent, but it's not a deficiency in dopamine in restless leg syndrome. It's a difficulty of the brain to get the dopamine from one area to another, so the transport of the dopamine chemical throughout the brain. But one prevailing theory that's coming up is it doesn't really, even though it uses dopamine, it doesn't overlap exactly with Parkinson's disease. It might be due to the Parkinson medications themselves, because Parkinson medications are used to treat restless leg syndrome because of how they affect dopamine. And some of the Parkinson's drugs, if you take them for a long time, the restless leg syndrome will get worse and worse. So one of the theories is because patients are on these Parkinson's drugs, for Parkinson's obviously, and it makes people with restless legs worse, it may bring out the condition of restless legs in patients who would otherwise not have it, which is why it might be more common in restless legs. So this condition is diagnosed by a physician. Typically there's no test for it. Now, if you were to do a sleep study, and I'll show what a sleep study looks like later on, but some patients can have what are called periodic limb movements where their legs twitch or jerk on a regular basis, like every 30 seconds they may have movements where their legs jerk, and you can pick up this on a sleep study. And a lot of people who have these leg movements during their sleep also have the restless leg syndrome. They're thought to be related. And they're often associated with low iron levels. And people who have low iron levels, for various reasons, have low iron levels in their brain, and that the iron is involved in the transportation of dopamine in the brain. So people who are anemic, people who have kidney disease have low iron levels, and they often will develop restless leg syndrome because they can't transport the dopamine as effectively. So with this condition, again, just like REM sleep behavior disorder, it doesn't have to be treated. So the first thing is to figure out whether it's something that's bothersome enough to be treated. There are certain drugs that make the condition worse, and some of them are antidepressant medications, which change the chemistry of the brain, and it kind of makes people more prone to restless leg syndrome. And antihistamines are another one, things like Benadryl or some of the sleeping pills like Unisom, which are antihistamines, that sometimes will make the condition worse. So if someone's on an antidepressant that they don't really need, then we may consider stopping it. If or taking Benadryl or antihistamines, we might switch to a different type of allergy medication, for example. And then the drugs that are generally bad for everything, like nicotine, smoking, are also make the symptoms of restless legs worse. Caffeine and alcohol generally make it worse too. So avoiding those substances, particularly in the evening, can help without having to use medications. So I mentioned that having low amounts of iron in the body can make someone develop restless legs. So typically, a chemical called ferritin is checked, and ferritin is very sensitive for picking up low iron levels. And when the ferritin level is low, it often reflects that the iron level in the brain is low. And if you get a blood test for ferritin, your blood test may come back normal because the scale is designed for people who have anemia or low blood counts. But we actually have seen restless legs get worse in people with low normal levels of ferritin. And typically, if you want to look at numbers, it's 75 or less. If the blood test is 15 or 20, that's low for restless legs, even though the blood test says quote unquote normal. So that's something that we'll look out for. And then if the iron levels are low or low normal, iron supplementation sometimes helps with this condition. Unfortunately, one of the main side effects of iron is constipation, which is already a problem in Parkinson's disease. So stool softeners have to be increased and used, and it can also upset the stomach. Sometimes we actually put iron in through an IV and give iron infusions so people don't have to actually take iron through their mouth. So there are drugs, if the symptoms are bad enough, there are drugs or medications that we can use for the condition. The most common ones now, the first ones we use if we have to use a prescription drug, are drugs that you may have heard of. Gabapentin and pregabalin are two of the more common ones. And you may have seen commercial, Neurontin, Horizont are the brand names. Horizont is a drug, it's a type of gabapentin that gets into the bloodstream very effectively, but it's not covered by most insurance companies, including Medicare, so it's very hard for us. We rarely are able to prescribe Horizont, but that's really the best drug. And Lyrica, you've probably seen commercials on TV for it even recently, and this is a very effective drug for restless leg syndrome. The side effects of these drugs are they cause sleepiness, which is sometimes a problem, but again, this is a drug that's usually only taken in the evening or before bedtime, so it's before someone would be going to sleep. Sometimes people feel a little bit off when using the drug, and rarely they can cause swelling in the feet and ankles. Those are the main side effects. And then another treatment, this used to be more first line, but now we're not using these drugs quite as much, but many of you are on these drugs or know someone who are on these drugs, but these are the dopamine agonist drugs, and drugs like pramipexole or ropinirole or the rotigotine skin patch or Nupro. And these drugs have been used for restless legs for a long period of time. Of these drugs, we recommend Nupro because Nupro is a patch and the amount of drug that you get is 24 hours, and there's not peaks and troughs just like you would have for Sinemet. And it tends to not make the condition as getting worse over time. Now, these other drugs, some people who take them for many years start to get worse and worse symptoms. So it can actually make the condition a little bit worse over time. But initially, these drugs work very well. But these are also some of the drugs that are thought to make it more common in patients with Parkinson's disease because these drugs are often used for Parkinson's disease as well. And as I mentioned, some of the drawbacks to look out for are these sleep attacks, which we mention from time to time, or these sudden feeling that that you can't stay awake, and that can be a problem if you're driving. And the biggest two side effects other than that are that sometimes the drugs can cause compulsive behaviors. So more drinking than usual. Maybe if somebody gambles, they might develop gambling problems or shopping problems, or even doing repetitive tasks over and over again. So we always screen for those things. We even had a woman who used to read a book for 30 minutes a night, and she began reading 3 hours before bedtime every night. So it could be even minor things that aren't harmful, but people do them too much, and that could be a side effect of these drugs. And then, as I mentioned, the thing called augmentation, where it can make the restless legs worse over time. But what can happen is someone can be switched to a different drug and be taken off of these drugs potentially, and it can help to reset the body, and the condition will get better. And then in rare cases, we use opiate or painkiller medications, which actually help for the symptoms as well. Things such as tramadol, oxycodone, or Norco, we use in very, very, very low doses because they do have a lot of side effects. Once again, these pain medications can cause some drowsiness or disorientation, and they also cause constipation. So in Parkinson's disease, these would not be as readily used as people who don't have Parkinson's disease, but they're an option if they're already being used for other conditions usually. So I wanted to touch a little bit about insomnia and the body clock. So insomnia is basically a fancy term for being unable to fall asleep, and a lot of that has to do with the body clock. So the body has a clock, and it determines when someone is awake and when someone's asleep. And this is kind of a little bit of a complicated diagram, but it's kind of interesting because there are two parts. The one that's called sleep homeostasis is the one on top, and that's sort of the drive to help fall asleep. So as you're awake during the day, you develop more and more fuel, for example, to fall asleep at night. So the longer you're awake, the more likely you are to fall asleep. And when you sleep, you use up that drive to sleep, and then you wake up in the morning. But there's also a second thing going on, and that's the time clock that the body has. And there are different times of the day that the body clock is more alert. And one of the times that you're more alert is right now, a little bit before lunch. And the person who's speaking at 1 o'clock will notice that people tend to get drowsy at 1 o'clock and will fall asleep during the presentation after lunch. It's not really because of lunch, but it's because after lunchtime, there's a dip in the patient's body clock. And that's seen by the sort of that yellow cloud image of where it dips a little bit around between 1 and 3 o'clock. So those are the two parts that come together. And I'm just going to use my laser pointer here. And so at this point, the body clock starts to slow down just after 9 o'clock. And the drive to fall asleep becomes its highest at that time. And this is when people start to fall asleep. And you can see this is when people tend to sleep in this curve here. So when that happens, those two things come together, and that's when people sleep. So if people are going to bed way too early, that could prevent them from falling asleep because their body clock's not ready. And if they take naps or they haven't been awake for long enough, they haven't built up the drive to fall asleep. So that's sort of how sleep works, is that it's built on being awake a long time and also being at the right time of the day. So the definition of insomnia is the inability to fall asleep in less than 30 minutes. If you can fall asleep within 30 minutes, that's considered normal. And it also can include long periods during the night when you should be asleep, but you might be awake and not able to fall back to sleep. And then some people wake up a lot earlier than they should. They wake up after 5 or 6 hours of sleep. And a recent study on people with Parkinson's disease show that almost 81% have a sleep condition that, or a condition that actually causes some disruption and some insomnia to their sleep. So this is pretty frequent in Parkinson's disease. So what are the causes of this? Well, as I mentioned, if people who try to go to bed too early, if they have to wake up early, they might try to go to bed too early and their body clock isn't ready to go to bed. Some people take long naps during the day, and the naps destroy that fuel that you need to help fall asleep at night. So if you take a 2-hour nap during the day, it's going to be very hard to fall asleep at the right time during the night because you haven't been awake long enough. And then other conditions like anxiety and depression, people who basically jet lag themselves by waking up at different times of the day or different times of the morning, that can cause a disruption to the body clock. And then some of the conditions we mentioned, like restless leg syndrome, can prevent people from falling asleep. And then a condition called sleep apnea, which I'll talk about in a few minutes. And then certain medications can keep people from falling asleep. So specific to Parkinson's disease and conditions like Parkinson's disease, are the condition itself lends to a lack of movement of muscles. And during the night, even though people are asleep, almost everyone moves around a lot because you can't be in the same position at all times. There has to be some natural movement, otherwise your muscles and joints become uncomfortable. And in Parkinson's disease, that's the main problem at night, is that especially if the medications are wearing off during the middle of the night, patients with Parkinson's disease may not move around as much and their bodies become uncomfortable. Then they wake up and they have to actually get out of bed and move around, or they develop cramps or pain, and that keeps them from falling asleep. And then there's also possibly a link between a disruption to the body clock and the disease itself, because it's interfering with some of the processes in the brain that help set the body clock. But we don't have as much evidence for that right now, but that's what's suspected. So what are some of the treatments? And most of these aren't really medications. They're different lifestyle changes that one could make. And one is to keep a very consistent wake-up time, because the wake-up time is when the body clock starts. So the body clock will be on a regular schedule and this goes for anyone, when someone wakes up at the same time, it doesn't matter when they go to bed, but when they wake up at the same time every day, that's what starts the clock for the day. And avoiding naps is also a key, because I showed that part where you need to be awake a long time to fall asleep. If you take a long nap during the day, that's going to harm your ability to fall asleep. And if you have to take a nap because you're so sleepy, we recommend naps no longer than 20 minutes. Actually setting an alarm for 20 minutes, a cat nap or a power nap will help to improve alertness but not cause difficulty falling asleep during the night. And then if there's another condition like anxiety or depression, to seek treatment for those conditions, because that can sometimes keep people from falling asleep. And if they treat their anxiety, their mind will be relaxed and they'll be able to fall asleep. And if these other measures don't work, the Sleep Center has more advanced ways of treating insomnia, and that usually involves being referred to a specialist who does sleep disorders as well. So some of the ones that I found that tend to work well for patients with Parkinson's disease is sometimes people who are on some of the longer acting drugs, like I mentioned this Nupro patch that is sometimes used for restless leg syndrome. It's sometimes used for Parkinson's disease, and sometimes that patch can help in certain cases if you're the right type of patient. It could help to keep the movements a little freer at night and allow for more natural body movements during the night so that you don't become uncomfortable. And there was recently a study with long-acting Sinemet, but not really Sinemet, but the intestinal gel that works over a long period of time. That was shown to be effective in treating problems with sleep. And then we just had the talk on deep brain stimulation, and the deep brain stimulators, especially when they're used to reduce rigidity and free up movements, that actually improves sleep quality as well and reduces insomnia in a clinical study. So I'm going to talk a little bit about obstructive sleep apnea. This is a very common condition, and it's not specific to Parkinson's disease, but it can happen in patients with Parkinson's disease as well. But what this is basically a blockage in the airway in the back of the throat. And what it does is it interferes with sleep because someone's throat collapses, they can't breathe, and then they wake up briefly from their sleep. It also can cause drops in oxygen level because the air is not getting in. So in this diagram here, the picture on the left is somebody who would be sleeping normally. Normally, people breathe mostly through their nose. The air goes in through the nose, down the throat, into the windpipe, and into the lungs. But if the back of the throat is a little floppy or it's really small in size, sometimes the throat can collapse because the throat's made of muscle. And sometimes it can collapse and it can cut off the airflow. And when the airflow gets cut off and someone can't breathe, they have to wake up briefly to get that air in, and then they fall back to sleep. And this can be very disruptive to sleep. So it can lead to very short awakenings. Most of the time, no one's even aware that they woke up because it's for a few seconds. And but it can cause effects similar to sleep deprivation and reverse all the good things of good sleep. You would have all the bad things: difficulty concentration, decreased mood, not being awake during the day. And one thing to note is that snoring is not normal. It's considered normal because it's so common, but the majority of people who snore have sleep apnea because they snore because their airway is collapsing. Normally, sleep should be silent. So if you know someone or you do snore yourself, you have to really talk to your doctor about this, because it could be a sign of sleep apnea, and the majority of people who snore have sleep apnea. And it's very common in the United States. It could be up to 20% of the population, the adult population now. But it's not necessarily more common in Parkinson's disease, but people with Parkinson's disease probably almost up to 20% probably have it, because that's the number of people who have it in the US population. So this is what I had mentioned, a sleep study, and this is an example of one. The most common sleep study, particularly if it depends on insurance, but for Medicare patients specifically, is one that you have done in a sleep laboratory. And you become a robot. You get hooked up to a bunch of wires, and then you sleep for the night. It's like a bad night in a bad hotel room. And so you sleep for the night, and the sleep, they measure brain waves, they measure the airflow through the nose and mouth, they measure the effort of breathing, and they measure the oxygen levels. And then they can measure things like muscle tone on the chin or muscle tone in the legs to see if there's kicking movements or if there's other types of movements. So it's helpful for a couple of the conditions that I mentioned, like REM sleep behavior disorder. But this is how we diagnose sleep apnea, because we can see that the airflow gets cut off and then the brain wakes up from its sleep and the oxygen level drops. So that's how we diagnose it. And the main treatment, I'm sure almost all of you know somebody on CPAP, but CPAP stands for continuous positive airway pressure. And what CPAP is, it's a device that puts pressure into the nose, and it keeps the back of the throat from collapsing, sort of like how your car tires don't go flat when you drive on them because there's air pressure holding them in place. So this is an example of the CPAP, and it's a mask that goes over the nose, and the machine puts a little bit of air pressure into the nose, and it keeps the throat from collapsing. And in most cases, CPAP is basically 100% effective and has no long-term side effects, because it's not a surgical procedure and it's not a medication. So it's a temporary treatment, but it's in most cases nearly 100% effective. So as I mentioned, the snoring and disruption to sleep should go away completely with the CPAP. And it may lead to things like fewer trips to the bathroom, because sleep apnea causes people to have to urinate during the night. And if you have trouble walking and getting out of bed, the fewer trips to the bathroom, the better it is for safety. And the main drawback, as I mentioned, it's a temporary treatment, and then getting comfortable with wearing equipment at night and wearing a mask are usually the biggest obstacles, but there are no long-term side effects of this type of treatment. So I talked about the main sleep conditions, but some people are still sleepy even if they don't have these conditions or these conditions are treated. So there's kind of the three main things with sleep. It's very simple. You have to have enough sleep, so the quantity of sleep has to be enough. It has to be good quality sleep, and the timing has to be good. And we talked about all those things. So if you get enough sleep and your sleep quality is good, and you sleep on a consistent with this consistent time that you wake up, then typically you're not going to feel pretty sleepy during the day. But there are other causes of sleepiness that don't necessarily relate to sleep. Some of them can be medications. I even talked about some medications that we use that cause sleepiness. But even medications that might be used for Parkinson's disease, like dopamine agonists, in some cases people can become sleepy or have sleep attacks on them. Mental health problems such as depression can cause people to be very fatigued or very sleepy as well. So if these are other causes that we might look for if they're not some of the more common sleep disorders. And if your doctor or you can't figure out what the cause of the sleepiness is, you could always be referred to a sleep physician, and the sleep physician can do some investigation as to what are the potential causes. So the medications we sometimes use for people who are sleepy and we don't have a cause, or the causes are all treated and we can't figure out why. One of the common ones, you guys may have all used it this morning, is caffeine, coffee. This is the most common medication that produces alertness. And this is one that a significant number of people use, and it's fairly safe. It does have potential side effects if you drink too much caffeine. And there are newer drugs that are prescription, like modafinil. The brand name is called Provigil. And this is a very safe medication with very few side effects. And it causes a level of alertness that a few cups of coffee would without the jitteriness. And so this is a potential drug that we might use that's a prescription drug. So just to summarize the things we have gone over, sleep is very important. We spend a third of our lives sleeping, and sleep quality affects our lives both short-term and long-term. And most sleep problems have treatments, so it's important to look for them because they could be affecting other aspects of your life. And in Parkinson's disease, the ones to look out for is this REM sleep behavior disorder and restless leg syndrome are the two that are a little bit more common, especially REM sleep behavior disorder, a lot more common in Parkinson's disease. And looking out for ways to avoid insomnia and the inability to fall asleep and to treat that. And then everybody should be on the lookout for obstructive sleep apnea because it's such a common and easily treatable condition. And if you're still sleepy, make sure you talk to your doctor about a referral to a specialist who can specialize in sleep because it's something that can be potentially helpful. So if anyone has, I think we may have a few minutes for questions, so if anyone has any questions. We have a couple over here. So the question was whether I recommend an adjustable bed. So an adjustable bed is potentially very helpful for many different reasons. For one, with Parkinson's disease, it helps with getting out of bed and mobility and actually changing positions during the night, which is important. But it also can be used for certain things like sleep apnea is often better when patients are more upright. So we often will, even with CPAP, we will put patients on an adjustable bed where they can be at a 45-degree angle. So it's actually helpful for multiple conditions. So if potentially that would be something we would recommend. We do recommend that a lot.
I've been dealing with this for quite a long time. Been through your sleep study about 3 times, and nobody can seem to come up with an answer. I was at a dinner one night with other people we were not familiar with, and one man has developed a bite splint that I guess dentists are using now. Have you ever heard anything about that? He literally chased me out to my car telling me if I didn't use his bite splint, I was gonna die.
Yeah, so I didn't get into the main treatment for sleep apnea is the CPAP. So I talked about that, but there is a device that's like, one name is a bite splint, but basically it's like a retainer that you would wear, a dentist would make it, and it actually pulls the jaw forward at night to create more space in the back of the throat to keep it from collapsing. And that treatment is not considered first line because it's almost never as effective as CPAP. But for some people, they do use it for treatment of sleep apnea. It's not effective for everyone, and it's only effective for mild to moderate sleep apnea. So that would have to be a discussion with a sleep physician as to whether somebody with sleep apnea would be appropriate for that, but it is widely used. It's probably the second most common treatment for sleep apnea.
Okay, my question is, my father's a neurologist said that he must take a nap every day for his Parkinson's, that it's mandatory. And they said for him to regenerate or rejuvenate his dopamine, his own personal, dopamine. Can you talk a little bit about that, the importance of taking a nap and, why?
So I'm not aware that the sleep itself, especially taking a nap, would restore a dopamine function or increase the amount of dopamine by taking the nap. It may be more something that movements in general, if someone becomes sleepy or fatigued, their coordination, their movements are not going to be as optimal. And it may be just an effort to recharge that system by, boosting the energy level in the middle of the day or making the person more alert. I don't have any evidence to say that it would affect dopamine levels themselves, so I'm not aware of that. But long naps often can be disruptive. There are certain countries where people take very long naps during the day, and that's part of the culture. But in the United States, most people get their sleep at night. So if it's not part of the natural routine or cycle, we generally don't recommend naps greater than 20 minutes because it will disrupt the sleep at night. especially in a culture where we all tend to sleep almost always at night, rather than with siestas or long periods during the day where we have built-in sleep.
Yes, I have sleep apnea, and I was told that I had like these night terrors, and that was associated with sleep apnea. But now I'm seeing this REM sleep behavior disorder, and I had those where I would wake up screaming and whatever. So once you have those, do you always have them? Because I haven't had it like in like a year or so now.
Yeah, so what you're speaking of, it's a different condition that I didn't talk about. It's called night terrors, or we commonly call them sleep terrors, and they happen more commonly in children, where in the first half of the night they may wake up from their sleep screaming and then be disoriented and then just fall back to sleep. And that can happen in adults too, but that comes from a different stage of sleep. That comes from deep sleep. So a lot of people will wake up from their sleep from sleep apnea, because sleep apnea, again, it's disrupting the sleep. It's a waking up someone who might be in any state of sleep because they stop breathing, and that can precipitate what's called a sleep terror. But they also could be actually a nightmare, and you get woken up from your dream sleep, and then you have a nightmare, and you're waking up in the middle of your nightmare. So there are different types of behaviors, and they may not fall into this category of REM sleep behavior disorder. REM sleep behavior disorder is specifically acting out a dream. So the person's not awake, and so they're not waking up from their sleep. They're just acting out the dream that's going on in their sleep. But you'd have to talk to a doctor about how to distinguish between that. We can often do that on a sleep study. But there's different things that could be. And it sometimes gets better. If it's a sleep terror, it may get better with treatment of sleep apnea because it's not as disruptive to the sleep.
Because I wear my CPAP all the time. I can't sleep without it.
Right, so that might have improved the disruption of the breathing for your sleep, and now you don't have the waking up in different states of sleep from the breathing. So the treatment was actually the sleep apnea treatment.
Okay, so you think that's two separate things? It's not the sleep behavior disorder?
It may be, yeah. It requires a lot more detail than I can get into now, but that's sort of on a case-by-case basis. Sometimes it's hard to tell there's a couple different types of conditions.
Yes, in women who are undergoing pre-menopause or going through menopause or post-menopausal conditions, is there any research that indicates that hormonal changes have any effect on REM, sleep apnea, relevance to Parkinson's disease?
So yes. So the main thing is that, particularly with obstructive sleep apnea, women who go through menopause will start to develop sleep apnea at menopause because the hormones that help with the reproductive cycle help to keep the throat strong, and men never have those hormones, so men are always at risk for sleep apnea. Women tend to have equal risk to men when they go through menopause. So a lot of our patients come in their 50s who are women. So that's the main thing to look out for, is that sleep apnea in women can develop after menopause or at menopause. There could be some disruption to sleep by hormone fluctuations, hot flashes during menopause, but specifically deep sleep and REM sleep tend to decrease with aging, but it's not thought to be dependent on hormones or menopause. But the main things are hormonal disruption to sleep and then the increased risk of sleep apnea. But that would not be any different in Parkinson's disease than it would be in any other, in people who don't have Parkinson's disease. That would affect anyone equally.
You were talking about the incidence of restless leg syndrome in Parkinson's. There are a lot of people who probably have restless leg syndrome that aren't Parkies.
Correct.
What would you say is the incidence of the non-Parkie with restless leg and restless leg with Parkinson's?
Right, so it's a very common condition in the general population. It depends on each race because it tends to occur more in Caucasians. But in the United States, it could be anywhere between 5 and 10% of the population may have some degree of restless leg syndrome. Northern Europe might be even higher. Asia and Africa, it's much less. But the statistics I showed you for Parkinson's disease is 15 to 30%. So that's 2 to 3 times the number of people compared to people who don't have Parkinson's disease. And as I mentioned, even though both conditions involve dopamine, they might not overlap other than the medications themselves for Parkinson's disease, specifically Sinemet, may bring out more symptoms of restless legs. Because when you treat someone with restless legs with Sinemet every day, their restless legs will get worse over time if they don't have Parkinson's disease. So that's one of the theories as to why it's more common in Parkinson's disease, is that it's a long-term side effect of the medication. I'm not advocating stopping the medication, but it's just something that you should be aware of because it's very common in this condition.
I have a question.
Oh.
I frequently awaken during the middle of the night and find myself sleeping on the bedroom floor. I don't think I fall out of bed because that would cause me to awaken, but I find myself sleeping on the floor.
Yeah, so that's something to discuss with your doctor because during REM sleep behavior disorder, people don't wake up. And so they can fall out of bed and then they wake up with their head bruised or their arm bruised. So that's something you want to discuss with your doctor. There are conditions, as I mentioned earlier, that people actually get out of bed and sleepwalk. It's more common in children, but it happens in adults too. And so that's one possible cause, but REM sleep behavior disorder is a common cause of finding yourself out of bed if you are right next to the bed. If you're pretty far from the bed, it's usually not this condition, but you won't necessarily wake up from it. So you don't know how you got to where you are unless somebody's watching you. So that's something to be a little bit concerned about. And that's why I mentioned safety precautions, because you have to organize your bedroom as if you were to move around and not be aware. So you don't want to have, that's why it's good to have side rails and padded floors, because you could fall out of bed and not be aware of it. And you don't want to fall and hit your head on the nightstand. So you don't want the nightstand next to your bed. Because that's one of the causes. The condition itself is not going to harm you, but if you were to do some scary movement during the night, you could hurt yourself. And that's what we are most concerned about. Over here.
Yeah, for good health, is there a minimal amount of sleep that we should get that without waking up? In other words, 2 people sleep about 7 hours, but one gets awake either because you have to urinate or should there be like 3 hours in a row where you don't wake up, or 4 or 10%?
Yeah, so it's a little bit of a question of like how long should you sleep and what the quality should be. So it's always a case of like a spectrum. So it's obviously better to sleep the whole night and never wake up, though it doesn't often happen. And as people get older, there are more things that cause them to wake up. So it's a lot harder to avoid that. But ideally, the latest recommendation based on reviewing numerous studies is that almost all adults in the United States, or maybe in the world, need at least 7 hours of sleep. So if you could get 7 hours of sleep without waking up during the night, that's the ideal. But the ideal is different than what's realistic. But the fewer amount, the more what we call consolidated sleep is, the more you're in bed and the more you're consistently asleep, the better the quality usually is going to be. But there's no cutoff. And some people, it's different. Some people need 7.5 hours, some people need 8, some people need 7. But health problems start to develop when people get fewer than 7 hours of sleep. So that's why the recommendation was for adults to have more than 7 hours of sleep at night, total. So.
Thank you.
You mentioned the use of melatonin for treatment of insomnia. What about other medications like Zaloplan?
Yeah, so the question is more about medications to be used for insomnia. So there are a whole group of medications, Zaloplan, Zolpidem, or like brand name ones, Lunesta, a lot of the ones you see on TV, Ambien, Lunesta. So melatonin helps a little bit with causing drowsiness, but it's not a great sleeping pill. And all of the medications for sleep have potential side effects, and if they're used every night, they'll stop working after several weeks to a couple of months at the most. So for what we call intermittent use, so if you have a trouble falling asleep here and there, like once a week or a couple times a month, those are the times where a medication to help fall asleep may be useful. But in general, if you have trouble falling asleep every night, no medication will ultimately work long term. And that's when you need to see a sleep physician. And usually the treatments end up being behavioral therapy from a sleep psychologist. And I didn't get into that very much because that's usually somebody who needs sleep evaluation. But for short-term use, these sleeping medications are helpful here and there, but once again, they have side effects, and especially with Parkinson's disease, you don't want to be on a drug that's going to impair your alertness and your judgment if you're getting up to use the bathroom during the night and you're really drowsy because you took a sleeping pill. Your risk of injury or getting into an accident in the morning if you're driving, those all go up with sleeping pills, especially if you don't get enough sleep when you take them. So it has to be used very cautiously with the help of your doctor. But they can be useful for intermittent difficulty falling asleep.
Hold on, I actually have,
Oh, sure.
I have one follow-up question to that. So you mentioned in your slides that melatonin is over-the-counter, but you should buy a pharmacy grade. Any advice to everyone as to how to identify whether something is pharmacy grade, is not pharmacy grade, especially if they're ordering online?
Yeah, so it's hard to say because these aren't drugs that are manufactured by big pharmaceutical companies and they're not FDA regulated. But there are different forms of melatonin, and the companies will usually identify themselves as far as prescription grade. One is called Pure Encapsulations that we recommend. That's available on Amazon. But there are certain companies that advertise pharmacy grade, and they make different drugs for other. They might make other herbal remedies that are also pharmacy grade. And so it is very difficult to identify, but Pure Encapsulations is one that we commonly recommend that's available online. And you could also talk to your pharmacist because they may know more about each manufacturer at that, whatever CVS, Walgreens, Kroger, wherever you're getting the over-the-counter drugs. The pharmacist may know the quality of each brand because a lot of the cheap, really, really cheap ones, if you're taking 5 milligrams, it may not be 5 milligrams, it might be 2 milligrams because it's not regulated like these other drugs. When you're getting Sinemet, you're getting exactly what it says, but this is not as regulated, and it's not, so it's sometimes, if it's not effective, it's usually when we recommend to upgrade to, get one that's a pharmacy grade to make sure you're actually getting the right amounts.